Okay, welcome to MD Clone's Coffee Break. Today we'll discuss how to use data to uncover operational efficiencies. My name is Catherine Jean. I'm a clinical specialist with MD Clone. Prior to joining MD Clone, I was a nurse manager and transplant service line leader and used data to create the strategic direction of the transplant program. So I'm excited to share this approach to using data to create a sustainable model for data-driven decision-making in healthcare. Okay, so this is the agenda for today. We're going to go through the steps of the quality improvement cycle that we created with the transplant program. And we're going to go through how we use the Adams platform and each of the modules within the Adams platform, specifically Ask, Discover, Act, and Measure, to create the query and discover what opportunities lied within the workflow and the collaborating services within each of the time-related events that we added to the query, and then come up with a plan for action and then measuring that action through metrics to confirm that this is a sustainable change in the process. So in the Ask module, we started with a question of how do we increase operational efficiency in the kidney transplant surgery process? And to do this, we looked at all of the data variables that are necessary to be part of the equation so we could start looking into where the opportunities might lie. And we started by looking in the pre-transplant phase. And in that pre-transplant phase, these patients are first referred to the transplant clinic. They undergo evaluation. They're either approved or the selection committee asks that they do additional evaluation. But once they're approved, the transplant coordinator submits a surgery request. And then after that request for surgery, they undergo preoperative testing to confirm no new changes have occurred between the time of the request and the surgery itself. And then once that's cleared, the transplant surgeon will take the patient to the operating room and complete the transplant surgery. So this is the Ask module in the Adams platform, and we looked at a reference event defining the group of patients that we wanted to look into. And in this case, it was kidney transplant surgeries and had a cohort size of 1,692 patients who were adult patients over the age of 18 and underwent a deceased donor or living donor kidney transplant. So here we added some additional time-related events. We looked at the date of referral, the date of evaluation, approval, and when the surgery was scheduled. And the tool allowed us to look at the days between different reference events. So we were able to see how many days occurred between referral to evaluation, from evaluation to approval, and et cetera. We also looked at comorbidities of patients to see if that had an effect on the time it took for them to get through certain phases, such as the evaluation phase. So we saw if patients had a cardiac history or a history of malignancy or other services that they would need, additional consultations that they would need from specialty services to sign off on before they were approved for transplantation. And on the bottom graphic here, you'll see a timing definition, and that really helped us hone in on the timeline of when events were occurring with patients. So we looked at things like the last creatinine before being referred for transplant surgery, or for patients who were not on dialysis yet. We looked at what was their GFR before being referred for transplantation. So this timing definition allowed us to view patients in a longitudinal view and allowed us to really put together the picture of the entire patient's story from when they presented to the transplant clinic through to the transplant surgery. In the Discover module, we were able to find the days from different reference events. So from referral to evaluation, we saw it was taking 6.6 months. From evaluation to approval, it was taking 16 months. And by chunking those stages down and then further chunking it into workflows and collaborating services, we were able to brainstorm where the opportunities might lie. So in the referral phase, we found that patients were getting stuck in the scheduling of the evaluation. And the biggest reason why they couldn't get an evaluation appointment was because of the nephrologist availability. So we came up with an idea to create a time slot specifically for the nephrologist during certain times of the week and ensure that patients would not have to wait for the nephrologist to come back from rounds for inpatient patients or after they followed up with post transplant patients. There was a set slot from which patients would be dedicated time to see the nephrologist. We also looked at radiology services and found that patients were allowed to have their imaging only during certain times and days of the week, and it did not coincide with the days that they were coming in for an evaluation. And so we try to streamline those appointment slots to create a more like a 1 day workup rather than a 5 day long workup where the patient had to come back and forth for different aspects of their evaluation. So then from evaluation through approval, it was taken 16 months, and we tried to shorten that down to 10 months by also looking at how to streamline the transplant coordinator's workflow. From approval to the surgery being scheduled, for planned surgeries such as living donor transplants, it was taking 2 weeks, and for unplanned surgeries such as deceased donor transplants, it was taking 12 to 24 hours. So that was where we were very efficient in the process. And then from the surgery being scheduled to the surgery itself, there was some miscommunication with the check in and the preoperative testing before the surgery. So that's where we found some opportunities to decrease the progression time from 19 months to 12 months. Here are some visualizations that the Atoms platform allowed us to see. Here we see on the left graphic, 60% of this transplant program had deceased donor surgeries or unscheduled deceased donor surgeries, and 40% were scheduled living donor surgeries, which usually helps clinical operations when you have a scheduled surgery. So that was a good thing that we were able to see. The second graphic shows that it took 6.6 months from referral to evaluation. But when we looked further into the contributing variables, we found that there were a lot of things that were outside of our control, such as the readiness of the patient to be evaluated. So patients were being referred too early. So before their GFR was under 40, sometimes they would be referred. And because the evaluation approval only lasts a year, we didn't want to have to reevaluate them. So that really increased the time between referral to evaluation. Some patients were too sick or had an active infection, and so weren't able to be evaluated for transplant. So the referral phase is where we didn't see a lot of opportunity to change. The one thing that we did do is to engage the referring nephrologist to continue that relationship, to continue bringing patients into the transplant clinic. And the third graphic shows that it took 16 months for the evaluation to be complete. And here is where we saw an opportunity where we found a cluster of an age being around the age of 65, even though we had a range of patients who came in for a transplant evaluation. And when we looked further, we found that many of these patients required a cardiology consultation for approval. And so we decided to engage our partners in cardiac services within the hospital. And at the end of Discover, we started to see some opportunities by looking at workflows and the collaborating services. And we looked at some low hanging fruit. So we looked at our current resources and our sphere of influence, like what was within our control and where did we need other players. And so we had a list of interventions that we could do today. We had interventions that required a little bit of collaboration, especially in the evaluation phase with cardiac testing and radiology services. And then we had a list of things that we could do that required a long-term vision and required buy-in from leadership to support the ask in finding such things as a dedicated appointment slot with other service lines, daily operations, and to show a return on investment or ROI as to the entire benefit that both of our objectives would be met if we both expanded our services. So this is where we started to strategize and prioritize where we would focus our efforts. The ACT tool is a care management module within the Adams platform, and it allowed us to track some of the outreach that we did with patients. We also created some standardized protocols and policies and guidelines and processes around workflow for transplant coordinators. We used technology where we could, so embedded in the EHR, nurses have checklists and smart sets to order certain preoperative labs and infection serologies. They can also use smart phrases to document the clinical assessment and the checklist. They have a checklist to confirm that they overviewed certain education with the patient. So we try to use alerts and these types of tools in care management to ease the process for the transplant coordinators. We worked with cardiac services to have them come to the transplant clinic once a week and see our patients in person once a week so that they didn't have to have a different appointment time for the cardiac evaluation. And we were able to create a time slot of our own transplant patients who had for patients who required a radiology visit and imaging. We had specific time slots for them to plug into so that they always had a spot available when they were already here for an evaluation. So in the measure phase, this is where we marry together documentation of the things that we're doing with long-term tracking and reporting of the changes that we made. So before I mentioned the smart sets and the smart phrases and pre-op testing, those kind of things are ways that the program was able to track documented action. And based on when that took place, we were able to measure some different metrics that came from that. So here on the left-hand side, we'll see that the time to evaluation trended down. It went from 16 months to 10 months, and then even less time as time went on. The second graphic is showing that cardiac events, which is a clinical outcome, trended down over time. And then the third graphic is showing that there's a horizontal line in that third graphic, and that's showing before the intervention took place versus after the intervention took place. After we made some of these changes, we looked at clinical outcomes such as urinary tract infection, wound infection, reops, the need for dialysis or delayed graft function, and found that it was trending slightly down and also below that benchmark indicated by that horizontal line, but then also showing that everything after that initial intervention resulted in a green point showing that we were compliant with our benchmark. So by looking at the documentation, we created some dashboards and outcomes metrics so that we could create long-term strategies for continuous quality assessment and performance improvement. And as we decided on what we're going to change, we created standardized protocols. For example, infection protocols, blood type confirmation. And then we also looked at it in terms of the clinical outcomes of patients, because when you make an operational change, it may not only affect operations, but it may also affect the clinical outcomes of patients. And so anytime you make a change, you really want to give it 3 months and show that you're still being safe in terms of your clinical care while still creating an operational efficiency. So the moral is that incremental changes can yield big results. And we were able to increase the rate at which transplants were being scheduled. We found the opportunities for efficiency, we reduced bottlenecks, and it was a continuous improvement cycle where we continuously monitored how our changes were affecting the outcomes in our patients. And the big takeaway here is that service lines operate with leadership that have a lot of experience. But when you couple that with data, it can create powerful insight that will inform decision making. And so, again, the result here was that we increased the rate at which transplants were being scheduled and thus increased access to the transplant program, maintained and increased quality of care, and increased the throughput of the program. So in summary, we started with ASK. We looked at the progression time through the kidney transplant surgery process. We looked in the Discover module to see how and where we can make an impact and what was within our control, what were the easy wins, and created a list of changes that required approval or assessment and showed a business case to senior leadership when needed. In the ACT module, we were able to put into place the change management. What were the interventions that were needed? We created processes and workflows and used technology to automate when we could. And we measured those changes to ensure that the quality was still high if we were making operational adjustments. And we tried to hardwire that in our staff by creating sustained results. So throughout all of this, data was the common thread to achieve sustainable results. We created an operational dashboard, we tracked clinical outcomes, we created continuous quality assessment and performance improvement, and we were able to make a big impact with small incremental changes.